Welcome to Falcon Physician Review's Neurology Review session. The next module will cover motor systems, concentrating on the basal ganglia. I want to introduce you to different structures of the basal ganglia seen here in this coronal section of the brain. The main players here are the caudate, the putamen, the globus pallidus pars externa, globus pallidus pars interna, the subthalamic nucleus, and substantia nigra. The caudate and the putamen are connected to one another through cell bridges in the very anterior portions of these structures. Therefore, it creates a striated appearance in the anterior locations of the anterior coronal sections. This is the reason why these two structures together can be referred to as the striatum. The connections between these basal ganglia structures has been the bane of many medical students' existences. Most people decide, after struggling with it for hours and hours, that it's just not worth trying to commit to memory. However, we at Falcon Physician Reviews have come up with a technique that may improve your ability to retain this information. First, let me introduce you to the basal ganglia and the connections between these structures. A set of excitatory and inhibitory connections between structures allow a person to either initiate movement very easily or stop movement very easily. This can be considered the clutch and accelerator of the nervous system. Once you want to start many motor programs, such as initiating walking, one can just activate the direct pathway and start moving. Or if you want to stop walking, you can activate the indirect pathway and stop walking. Patients with difficulties in this, such as Parkinson's disease, have trouble initiating movements, and patients with Huntington's disease may have trouble stopping movements. Let's talk about these two pathways separately, and it's very difficult at times because there are excitations and inhibitions of different structures that can confuse the medical student. Taking this structure, we can see that the effect of the thalamus upon the cortex is excitatory. Therefore, whatever happens to the thalamus, if it's inhibited, the cortex will be inhibited. If it's excited, the cortex will be excited. Also, the cortex has an equal input upon either the direct pathway or the indirect pathway through through volition. Therefore, the cortex can be taken out of this image to make this easier to bring into your memory. Here's an image of the basal ganglia circuitry with that cortex taken out. Now this makes it simple. First, let me just show you the direct pathway where, without all the other arrows in place, very simple, the globus pallidus pars interna is decreasing activity in the thalamus, therefore decreasing movement, and the striatum holds back that inhibition of movement, and the more it holds it back, the more movement there will be. The indirect pathway, on the other hand, has more players involved. The globus pallidus pars interna is holding back the thalamus. The subthalamic nucleus helps the globus pallidus pars interna hold back the thalamus. So together they're a team of structures holding back movement. If they were left alone, there would be very little movement. But the globus pallidus pars externa does not leave them alone and tries to inhibit subthalamic nucleus. The striatum, however, inhibits that inhibition. Therefore, the end result is the substantia nigra, the subthalamic nucleus and the globus pallidus pars interna are left alone to hold back movement in the thalamus. Therefore, there's very little movement. The indirect pathway becomes very complex because the indirect pathway has many more structures that are being excited or inhibited. Remember that the globus pallidus pars interna is inhibiting movement through its effects upon the thalamus. So the globus pallidus pars interna is holding back thalamic activity and therefore holding back movement. The subthalamic nucleus is assisting the globus pallidus pars interna to hold back that movement. So together they form a team of structures to hold back movement of the thalamus, or movement created by the thalamus, or its effect upon the cortex, which would be excitatory. Now, the indirect pathway gets even more complex when you add in the effects of the globus pallidus pars externa, which is inhibiting the subthalamic nucleus. If you inhibit the subthalamic nucleus, you are lessening the excitement of the globus pallidus pars interna, and therefore decreasing the effects of that globus pallidus pars interna. Therefore, you would have more movement. However, the striatum exhibits a negative influence on the globus pallidus pars externa. Therefore, the sum of all of this input is a decrease in movement. The more I hold back the GPX, the more the subthalamic nucleus and GPI are holding back the thalamus. Therefore, there's less movement. If I excite the indirect pathway, I am inhibiting movement. To make this easier to swallow and to understand, we'll boil this down into the two different direct pathways using a story to help you remember it. First, let me just show you the direct pathway where, without all the other arrows in place, very simple, the globus pallidus pars interna is decreasing activity in the thalamus, therefore decreasing movement, and the striatum holds back that inhibition of movement, and the more it holds it back, the more movement there will be. The indirect pathway, on the other hand, has more players involved. The globus pallidus pars interna is holding back the thalamus. The subthalamic nucleus helps the globus pallidus pars interna hold back the thalamus. So together they're a team of structures holding back movement. If they were left alone, there would be very little movement. But the globus pallidus pars externa does not leave them alone and tries to inhibit subthalamic nucleus. The striatum, however, inhibits that inhibition. Therefore, the end result is the substantia nigra, the subthalamic nucleus and the globus pallidus pars interna are left alone to hold back movement in the thalamus. Therefore, there's very little movement. Now, let's use a vignette or a little story to try to commit this to memory. To do this, we need to pretend that we're going to the rodeo. So the first thing I want to show you is a horse, a bucking bronco, which is the primary attraction of a rodeo. This one happens to be called Old Thal because it represents the movement, represents the thalamus. That bucking bronco is the activity of the thalamus. It wants to move. It wants to move like crazy, and as long as it doesn't have a rider, it's going to move very well. But in any rodeo, there's a rider that wants to hold back movement of the bucking bronco. So he wants to get on top of that horse and hold it back. So what would he be doing to the thalamus? Globus pallidus pars interna is the cowboy that would hold back movement of that bucking bronco, Old Thal. That's not the only players here. Anytime there's a rodeo, there's somebody that wants to charge admission and make money off of that rodeo. This horse that's never been ridden is going to be tried to be ridden by globus pallidus pars interna, the big cowboy. So therefore, the rodeo director, the striatum, says, I'm going to charge money for this, and what I prefer is that the cowboy gets bucked off. He wants to have a good show, so he wants that Old Thal to remain unridden. So he wants to hold back GPI, globus pallidus pars interna, so that he doesn't ride as well. The more he holds back globus pallidus pars interna, the more that horse is going to buck. Therefore, this direct pathway is facilitatory towards movement. The more the striatum inhibits the rider, the more the horse moves. Now let's go to the indirect pathway. To do this, we have to add more characters. And this can get a little bit complex. But like any cowboy who's holding back that horse, any good cowboy's got a girlfriend on the side. That girlfriend is sitting in the stands of the rodeo. The stands would be STN, or subthalamic nucleus. So the girlfriend in the stands is STN. Of course, she wants to win the money to help that cowboy ride. So she cheers him on as much as she can. You ride him very well. And so the more she cheers him on, the better he's going to ride. So the team of subthalamic nucleus and GPI end up holding back that horse very, very well. What happens if he doesn't have that girlfriend? Well, he's not able to ride quite as well, and that horse can get away from him, and that would lead to a ballistic movement of the horse or the arm in the human example. So that would be called hemiballismus. In a patient with a subthalamic nucleus lesion, the patient may have ballistic involuntary movements. That's like the horse bucking, as the rider is unable to ride as well. So subthalamic nucleus lesions lead to hemiballismus. Now let's complete the indirect pathway. Remember, the cowboy wants to hold back movement. He's inhibiting the thalamus. The GPI is inhibiting the thalamus. The cowboy is holding back the horse. His girlfriend is a player in the stands. She's cheering him on. The more she cheers him on, the better he rides. But that's not the end of the story. Like any cowboy, he's got a checkered past. He's got an ex-wife in the stands. That's GPX. GPX wants him to get bucked off like crazy, would prefer if he breaks a leg. Now the GPX is going to get so frustrated and angry at that girlfriend who's cheering him on that a fight breaks out in the stands. GPX tries to hold back subthalamic nucleus, or the girlfriend. Well, the striatum, the rodeo director, can't allow that to happen. Even though he wants that cowboy to get bucked off as well, he can't allow pandemonium to occur in the stands. That wouldn't be good for business. So he holds back GPX. And the better he holds her back, the more GPI and subthalamic nucleus are able to hold back movement. Therefore, that is inhibitory towards movement. Now let's go to the effects of the substantia nigra. Substantia nigra influences the direct and indirect pathway through exciting the direct pathway and inhibiting the indirect pathway. You know, and you've overlearned the fact that the substantia nigra is something that facilitates movement. So the fact that you know that the direct pathway is excitatory towards movement means that you know the substantia nigra would want to facilitate that pathway. You also know that the indirect pathway is inhibitory towards movement, and so the substantia nigra would want to inhibit that pathway. And if it inhibits the pathway that is inhibitory towards movement, it's going to lead to more movement. So both of those effects, exciting the direct pathway and inhibiting the indirect pathway, will lead to more movement. A loss of the substantia nigra is going to lead to less movement and Parkinson's disease. That is overlearned information, which you guys should already have committed to memory. Let's do a clinical vignette. A 50-year-old male presents to an emergency room with wild flinging movements of his left arm and leg. He has been diagnosed with diabetes and hypertension and has taken his medications only irregularly. He is also a chronic smoker. On physical exam, you note uncontrolled, violent, rapid flinging movements of the left arm and leg. The remainder of the neurologic exam is normal. So these movements would be termed hemiballismus, ballistic movements of the arm that are uncontrolled. And the most likely lesion here is in the subthalamic nucleus. So subthalamic nucleus leads to hemiballismus. A 42-year-old male presents with depression, poor memory, jerking movements of the limbs and fingers. His father died of a similar condition in which the symptoms progressively worsened, leading to dementia until his death at the age of 50. On physical exam, you note chorea, a dance-like movement that is involuntary. He has the psychiatric evaluation and it reveals cognitive impairment. He has inattention and poor concentration without memory loss. He has depression. There are no other focal neurologic deficits. This patient has Huntington's chorea, which is an autosomal dominant movement disorder, which leads to degeneration of the caudate nucleus. Loss of that caudate nucleus causes involuntary movements. These look very uncomfortable when you're looking at the person, but it turns out they're not uncomfortable. Even though the patient is grimacing, these are just extra movements. However, the problem is that when this worsens so much that they are unable to feed themselves, then this can lead to death. If they're unable to control their own secretions, then they may lead to a pneumonia, which could cause their death. Here's an image of the pathology of a patient with Huntington's chorea. On the left is a normal basal ganglia with the normal caudate nucleus bulging into the lateral ventricles, and on the right is a Huntington's patient without that caudate nucleus bulging into the lateral ventricle. One should think about this as a CAG repeat. That's the genetic etiology of Huntington's chorea. It's found on chromosome 4, and this trinucleotide repeat can lengthen between generations and make the disease worse in the offspring of a patient with Huntington's chorea. That's called genetic anticipation. The offspring of a patient affected may have the disease at an earlier age and with a worse severity. This a very marked increase in the trinucleotide repeat may even lead to the offspring getting the disease before the parent. So you may have a patient that has Huntington's chorea, but you can't get a family history. He says his father is doing just fine or his mother is doing just fine, and but then later the parent gets the disease. That would be a case of marked genetic anticipation. Fortunately, periodically, although not as common as the disease getting worse between generations, sometimes that trinucleotide repeat can actually shorten between generations, where the offspring would get the disease with less severity than the parents. A 65-year-old male visits his family medicine clinic because of slowing of voluntary movements, bradykinesia, an unstable gait, and muscular rigidity. He also complains of tremor at rest that worsens when his grandchildren come to the house and make a lot of noise, emotional tension. On physical examination, you see infrequent blinking with mask-like facies. He has cardiopulmonary and abdominal examination that are within normal limits. He has muscle rigidity with passive movements, cogwheel rigidity. He has a pill-rolling movement of his hands and fingers, a resting tremor. The combination of these symptoms, gait instability, cogwheel rigidity, bradykinesia, and a resting tremor, make the diagnosis of Parkinson's disease. Any of those standing alone may cause may be a diagnosis of Parkinsonism, but you need those 4 components to have Parkinson's disease. Syndromes such as mask facies are certainly part of the disease, but where the person is not able to show marked facial expression and decreased blinking, these are seen in Parkinson's disease, but they're not part of the 4 components that are required to make the diagnosis. For treatment of Parkinson's disease, we would add dopaminergic agents. So L-DOPA is one of our mainstays of treatment for these patients. We need to replace the dopamine that is lost when the substantia nigra degenerates. Here's an image of the midbrain with a normal amount of substantia nigra in the upper slice and a decreased amount of substantia nigra in the lower slice. The patient with the lower slice, who provided the lower slice, has Parkinson's disease. The loss of neuromelanin is the cause of the decrease in darkness of that substantia nigra. This is an unstained section, so it's not a staining of darkness. It's actually just the neuromelanin that appears dark here. In addition, you can see a Lewy body, which is the pathologic hallmark of Parkinson's disease, inside of a cell, seen here.